We talked earlier about, for example, about targeting specific chromosomal translocation on genetic abnormalities. I mentioned DOT1L inhibitor for the MML, mixed lineage leukemia, so that it can happen in AML but also in ALL. So there will be this drug is to watch for the 411, 911, 11q translocations, and we will see how that works out in the future. That's a targeted drug. And maybe, yeah, I don't know if you want to talk about Notch inhibitors, if you were involved in those.
Yeah, so that's an interesting job. First is, when we're talking about these immunotherapies, because you use T cells, you can't use them against T cell leukemia. So all of them are limited to pre-B-ALL. Now, 25% of adults ALL, especially in the middle age group and young adults, are T cells. And you don't see them much after age 60s, and not less in children. And they usually do quite well, these patients. And I think they do even very well with pediatric protocols. So there is a mutation, there is a molecule that's called Notch1, which is a membrane receptor which is involved in transferring signals from other cells outside the cell to stimulate the target cell in order to proliferate. So in order to do so, the molecule is a transmembrane molecule, and there's gamma secretase that breaks it and lets the intracellular part go to the nucleus. So this mutation is quite common in T-ALL, about 50 to 60%, and the data suggests that this is actually a good prognosis, and maybe that's the reason why we see outcomes that are overall better. So that became an important target because there's a lot of preclinical data that if you block gamma secretase or by an inhibitor, you're blocking Notch1. And the mutation is an activated mutation. So then the gene is mutated, and this is constitutively acting, so it stimulates the cell growth. So we have the drug for Bristol Myers. There is an abstract in this ASH of 2015, actually presented yesterday as a poster. And it's about 25 patients that we use, a phase 1 study. And what we can tell, one of the main concerns of a Notch inhibitor was diarrhea, because the Notch is involved in the function of the GI. And if you block its activity, you get diarrhea, and that other drugs fail. So there is this side effect, but it's not in a way, it's not inhibiting. Clinically, there is, but it's not serious. It's reached the final dose of 6 milligrams in the phase 1, although it's possible to escalate it a little bit more. In terms of activity, there is some activity in about half of the patients, but one of them had a complete response, went to transplant and did very well. So yes, there is activity, and I think like many other drugs, either increasing the dose, because it's phase 1, although there is a concern because there was a toxicity in the solid tumors, or combining it with chemotherapy. And this seems to be because of its lack of diarrhea. The other interesting thing is the responses were also seen in patients that didn't have the Notch mutation, and that questions the mechanisms of action.
Well, maybe just there are other inhibitors, kinase inhibitors being tried, in mTOR inhibitors or some JAK inhibitors for the pH negative, pH-like ALL. So we'll see more coming out. But there's a lot of redundancy in the pathways activating and driving cell growth. So even if we may use a targeted therapy, getting away with it by itself, even if we can't do it in aggressive pH-positive ALL or CML accelerated phase. So I think we need to combine them. I think there will be a big role for immunotherapy. Transplant is an immunotherapy, some other immunotherapies, or in combinations. So I think there's a lot of things coming out. We shouldn't forget about inotuzumab, CD22, which is being evaluated. Just to be fair to mention it here, we just want to mention what's out there, that every patient can benefit. So I think that's another one we have to see.
Yes, so inotuzumab actually is, in terms of the target, is probably more favorable CD19. It targets CD22,
22, yeah,
which is more frequently in almost in every ALL. And the other thing
CD19 is very frequent.
Yeah, but see, there's another advantage. It
Yeah.
internalizes. When you bind the antibody, it internalizes, and now it's used with the same toxin of gemcitabine. It's now bound to anti-CD22. It internalizes. And the phase 2 data is very promising. The phase 3 in relapse is just being closed, and we're waiting to see. It's compared to chemotherapy. There's no standard, but there was some suggested. And the CLGB, or the Alliance group, is planning to add it frontline, like ECOC is doing with inotuzumab, to add inotuzumab to their frontline. The question there, it's not clear if it will be added. I think people are waiting to see what will happen with the phase 3. So it is a potentially very active drug with the remission rates. Single agents are very high.
That's why I mentioned them, but it's exciting. So now we can offer our patients those therapies.